Oh, hey, Chris.
Hey Chuck, how are you?
I'm fantastic. It's that time of year.
That's great. So every time in conference, I want to say, "Hey Chuck," and I can't because everybody mocks me when there. So the thing is now that the fellows either want to make the podcast or they don't want to make it on the podcast. So as everybody knows, first fellow of the year with me, Dan Hong, was all about being on the podcast, and subtly and not so subtly requested that I drop his name on the podcast because he's going to getting all these text messages from his friends. Second fellow of the year, something happened, and he's like, "You're going to talk about this on the podcast, aren't you?" And he started saying, "Hey, Chuck, guess what happened?" I said, "I would never do that." I had such an enjoyable time with the second fellow, Nick Colada. He was so fun to have on rotation because he nerds out about the same stuff I nerd out about. But we'll see how the third fellow goes, Eric. He's on rotation with me now. Loving Eric Jang. So yeah, best time of the year for surgeons and proceduralists, I will say in general.
It is really funny when you talk about conference because we were doing a research conference on Monday and it's just going down this freaking nerve pathway. And I felt like I was on the pod and I felt like I needed to be careful not to interact with you like I would on the pod to say enough of the friggin' nerve stuff. But hey, it is what
It
it is.
was the research meeting that I lead, which I guess for those that aren't familiar with it, but for our division, we do a monthly research meeting. And a couple of years ago, we made a change so that there was a rotating moderator for the meeting. That would be a different faculty member to talk, just in general about what's going on in the division, ask the fellows for updates on their projects that they're working on, and then talk about their own research program, which I think has been really fun because all of us do a ton of research, but just, we have our little spaces and niches. Just, like I do the nerve stuff, the clinical research. David does basic science nerve. You and Lindley do a ton of stuff with Could. You do a lot of stuff with the adolescents and sports. So, it's nice to be able to catch up on that. But yes, I also almost slipped into podcast mode because we were on Zoom. We were talking about nerve.
Yeah, it's really hard to keep up with one another. I mean, we have eight hand surgeons. We're all super busy. We're all doing different things. Obviously, we have overlap. The other thing I mean, I do love just getting together in person or even on Zoom. It's a substitute, but it's fun to hear what you are doing because I get a sense, but talking details is really helpful. So I do like the research meeting for that reason, for sure.
Absolutely. So yeah, it's a busy time of the year. Everybody's met their deductibles, and I've been hearing about it for many months now. I'm glad that our eighth hand surgeon has joined. Jason Strelza joined us from the University of Chicago, and that's I've certainly heard less. I've been waiting 4 months to get in. Honestly, it hasn't come up, but that's been replaced by. So I met my deductible. And I was on the unfortunate end of the schedule this holiday season because I had the surgical center where I work is closed on Christmas Eve, obviously closed on Christmas Day, but Christmas Eve is my OR day. Christmas Eve is also, or New Year's Eve is also my OR day. And the
Yep.
surgery center where I work at is closed there too. So I've been scrambling to find extra time, which I successfully have. But my schedule will off kilter for the next couple of weeks.
It's hard, but yesterday I had to, I mean, when you have it's almost like you don't want to get injured on July 1st with a new round of residents and fellows, or residents at least. You don't want to get injured right about now because the schedule is booked solid. Like I have squeezed and pushed, and there's almost no leeway. So if you have a trauma now, either it gets taken care of immediately, but kind of walking in the office and expecting to get a fracture taken care of is just almost impossible. It's honestly frustrating.
It makes it very, very challenging. I mean, it's been busy with the nerve stuff too. We did four plexus cases in 5 days, like big cases, one super big one and three kind of medium-sized ones. So it's been a busy time, and I'll be looking forward to some quieter times in January. But it's nerve, 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 a lot of other stuff, nerve, 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 which I love, but it's
I'm sure
I
you
don't know if
do.
this current pace is sustainable the month of December pace.
No, I think we all feel that way. I understand one of those cases you did. Maybe started at 7:30 and finished around 10 or 10:30 p.m. And for me, a 3 hour case is more than I ever want to do. But I admire those who have more endurance than me.
To be fair, it was a Wednesday, so it was an 8:30 start. And then by the time you actually start the case after setting up a plexus, you're solid 45 minutes into the room. But for us, obviously, you don't want to have to do those cases, but they are really engaging and exciting cases to do. And I think David Bergen and I have come up with a pretty good system. And we did a lot of work in that time. And patients doing well so far. So very excited to continue the nerve adventures in 2025. We do have a fun episode that we're going to do today about the future of hand surgery. I think you came up with this idea while you were sitting in business school class. Is that it?
I try to focus, but hey, sometimes the mind drifts. I don't know when I came up with the idea, and hopefully that, we come up with enough interesting topics. But I hope our listeners will also pepper us with different concepts for what the future of hand surgery will look like.
So when you emailed this to me, I immediately thought of the Conan O'Brien skit, and this is totally going to date me. But when Conan was on NBC and he was following Jay Leno, so he was in like the Eastern time zone. That's like the I guess the 12:30 slot.
Yeah.
Uh, I loved watching Conan back in the day. And it was, I guess, in the late 90s, and they would have this segment with he and Andy Richter would have called In the Year 2000, where they would just make these off the wall predictions, many of them hilarious about what was going to happen in the year 2000. And then we had the whole Y2K thing and everything. I feel like the future of hand surgery could be a little bit like that. So we'll see what you come up with.
Well, we'll let the listeners be the judge of how poorly or how well we may do. Yeah, I think there's some interesting things.
So first off, I want to thank our sponsors over at PracticeLink. The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job does not have to be. Join Practice Link for free today at www.practicelink.com / the upper hand. And we are grateful to Practice Link. They have been with us, I don't know, a couple years now, 3 years maybe. So thank you very much to them.
Yes, and they're always a great resource for our local residents and fellows, and you really do take care of them in terms of providing access to sporting events. So we were the beneficiary of that for a Blues game recently. So thank you, Practice League. So these are your hot takes that you came up with for the future of hand surgery in 2025 and beyond. So the first one I think is really interesting, and I know I've talked about this before. Carpal tunnel release will be performed by others, such as physiatrists and neurologists. Go.
And I might even, and people are gonna wince when I say this, it might be podiatrist. It's interesting. I learned a lot about podiatry. Podiatry is licensed to do hand surgery in some states, which makes no sense to me. But I think the point is, have we gotten to a stage where the technology allows a simplistic approach to treating carpal tunnel syndrome? And some of this prediction is tongue in cheek because I don't know that I truly believe that, but I do think it's not going to be 100% hand surgeons indefinitely.
It's not right now.
Well, it's not right now. What percent? It's got to be
Well, I don't know, but I mean, I think as listeners may know, at least in the US, there is a new ultrasound guided carpal tunnel release device and an ultrasound guided trigger finger release device. And while they are currently training hand surgeons only, I am fully aware that their plans are to train non-hand surgeons to do this surgery too. And that could be neurologists, PM&R. They've approached people in our PM&R division about doing this surgery, and I think there were internal discussions from what I understand, and the carpal tunnel release remains firmly in the domain of the hand surgeon. But and also orthopedic surgeons and plastic surgeons and general surgeons. I mean, people who have trained to do the actual surgery. But yeah, no, that's coming. It scares me. I think one of our partner David Bergen talks about how he's more stressed about a carpal tunnel release than a crazy plexus case because the expectations are completely different. I mean, you have to be perfect on every carpal tunnel. I mean, you should be, I think. Whereas a crazy plexus is like there are only a handful of people, not a handful, but there's only a certain number of people in the US and then internationally, of course, that are, really doing plexus surgery. So there's a lot of variability in the case presentation, a lot of variability in treatment and expectation. So the bar is very different.
So should hand surgeons be teaching non-hand surgeons? And again, we're not trying to exclude orthopedic surgeons and plastic surgeons who are trained, but should hand surgeons be treating non-hand surgeons to do these surgeries like carpal tunnel release?
I think it depends on, I think, there are some people, who feel very strongly that if you can't handle and deal with the complications that a procedure generates, you should not be doing said procedure. But also there are probably access issues in terms of getting in. And I think some of the marketing around at least this current ultrasound guided device is that there are a lot of people who don't want to have quote surgery, and you're seeing a hand surgeon. Even though a lot of what we do is non-operative, people still have that mentality. When you're seeing the surgeon, they're going to want to do surgery. If you can make a carpal tunnel release a quote procedure that's done in the office by a non-surgeon, maybe it's a little less intimidating and makes people more interested in having it done.
Yeah, I mean, this is the hallmark procedure for hand surgeons, no doubt about it. And it's not glamorous, but there are, I guess I would say there are challenges, both diagnosis, counseling, and technical. And the vast majority of time, things go just fine. But I don't know the numbers you quote for a successful outcome in carpal tunnel release, but it's not 95%. It's just not. So it's an interesting concept.
Yeah, no, I agree. And I will say to be fair, there I've seen some incredibly skilled PM&R docs and neurologists use the ultrasound to do some really skilled procedures, like very challenging procedures. I mean, when I was up at Mayo for as part of the government travels, government scholarship travels, I watched them do some ultrasound guided thread carpal tunnel releases, which is really cool to do. Alex Shin was doing that with the physiatrist together, and did a lot of them, and they looked great. I think it's probably a combination approach, a collaboration approach that would be best. But just the physical amount of time that you need for two busy doctors to do something together is hard for something as relatively routine as a carpal tunnel release.
Yeah, nothing to add. So yeah, maybe I don't know. In 2030, will it be 25% of cases are done by non-hand surgeons? I don't know.
Yeah, I don't know, and I don't know if I guess there's an admin data study waiting to happen in the future, so we'll see.
We will see. All right, number two, um, the thumb CMC joint will be treated with implant arthroplasty alone.
You mean in the United States? Because it's already being done other places.
In the United States,
In the
by
United States.
by 2030, CMC will be an implant arthroplasty procedure, and we won't be doing FCR. We won't be doing suture suspension plasty. We won't do an implant. I like the suture implants. What do you think?
No.
And
I do
and
not think that's going to happen.
and why? And why not?
I think that it's going to take a lot to change surgeons' minds about what to do in the US. And I think the track record of multiple unsuccessful launches of implant arthroplasty for thumb CMC in the US market has, and honestly, I think it's probably killed the procedure potentially for future generations. I was intrigued. We had a visitor come from South Africa last year, and he was talking about his thumb CMC experience and implant arthroplasty, and I was intrigued. And then I have enough happy thumb CMC patients who are treated with trapeziectomy and suspension of some sort, where I'm not going to change. So it would require a fair bit of evidence, and those studies are expensive and are probably not going to be done.
I think that's well said. It's so interesting and sometimes frustrating, and I will leave the person nameless, but and I don't think you do it this way, but as an example of kind of the challenge of having surgeons change. In conference, we were talking, I think in research conference, we were talking about, or else clinical conference, we were talking about how we approach the CMC joint, straight dorsal or Wagner. You might call it the Wagner approach.
I'm not
Uh,
as fancy as you with the Wagner.
and one of our partners who I have immense respect for only uses the Wagner, and I just don't understand it. It doesn't provide better access. You do have more nerve irritation afterwards. Why in the world will we do that? It's just that's how that person was trained, and deviating from that course, it's just hard.
Right. It's very hard to change people's minds when they have success with something, right? Like, why would they change? Like, that's
Right.
what works in your hands, right? We actually have two partners that use the Wagner routinely. So,
Are you one
but
of them?
No, no, we're not going to call them out because but actually, I think if you're doing the Genie Del Signor technique, it's actually easier from a Wagner. It's quite challenging, I think, to do from a dorsal approach.
Oh,
But our partners aren't using that technique as of right now. But just saying there are technical reasons to use a Wagner. If that's your preferred suspension. You're much older than me,
much.
and trained in, back when I think, people were being admitted before carpal tunnel releases, and sent home after 3 days in the ICU. So, what was the feeling about implant arthroplasty back when some of those implants were being introduced in the 90s in the States?
I was taught with the classic Burton and Pellegrini FCR, um, and there was a widespread skepticism with the introduction of any implant arthroplasty. And so, at where I did my residency here at WashU, in Cincinnati with Peter Stern, Tom Kiefaber, and others, and then back at WashU, I don't think I've never seen an implant arthroplasty performed.
Do you feel like there is a chance for it to be adopted in the United States? Like, what would it
Um,
take?
Yeah, it would take an amazingly convincing study. And it would also take an articulate proponent of the procedure, sharing his or her results repetitively at national meetings. I mean, it would be a slog to change the perspective of so many people. I think it could happen. I mean, given the success of hips and knees, and I mean, you would think that there's at least amongst orthopedic surgeons, there is an underlying acceptance that implants are great, um, but it's just not for hand surgeons.
Do you think that there's a market to develop said device? And obviously it's been developed in other countries, and there have been reports of excellent results internationally.
I like to your point earlier, I just don't think in the United States we're ready for it. I think that's the hope that colleagues overseas will share compelling results that aren't like a skosh better than our results, however we're doing it. They have to be notably better. Decrease early failure rate, decrease late failure rate, and really happy patients. Because the reality is, I think we all know there is one truth, and this one truth that will prevent me from ever doing a prospective randomized trial again if the results are always about the same. Whatever you
Well,
do
yeah, I
to the
mean, it's
CMC joint.
really, I won't say that, a thumb CMC surgery is as reproducible as a carpal tunnel release. But I mean, I think that's the issue that, studies have when they're trying to show that they're not significantly different, compared to an existing gold standard, gold being a relative term, right? And then, it's not, and you'd actually have to show that you're better, which in some ways can be harder. So I just don't think the evidence is going to come. And I think it does have to come from somebody who is respected, articulate, and not crossing into the line of evangelistic. Which I think a lot of people who do, when they feel really passionate about something that they've innovated, it does come across as evangelistic at times, which, right or wrong, but you're just so into it and in the weeds and invested.
Yeah, well said. I mean, the what was the last great shift in hand surgeon behavior? Was it the volar plate with George Orbe?
I think the volar plate is probably the one that we would recognize. I think we're having Sanj back on pretty soon, and you guys will talk a little bit about maybe a shift in arthroscopic treatments before the volar plate, microsurgery.
Yeah, and the other distal radius innovation that I think has been rapidly and widely accepted is the spanning plate. Um, those are both were big changes. But yeah, let me back up and just maybe as a future of hand surgery number three will be wrist arthroscopy will continue to evolve. Maybe some fits and starts, but open scapholunate ligament repair will be historical. And I think the future of hand surgery includes all arthroscopic treatment, just like the evolution of rotator cuff repair.
I think that's probably right. I mean, and I also think to piggyback on your three, I'll make it a 3A. I think in 10 years, you're going to have arthroscopy fellowships for hand and wrist and elbow.
Yeah, interesting.
Just
Why
like
not?
people have like, your extra 3 months that you do for 6 months for peds, and some people do it for micro. I think they're going to be arthroscopy fellowships, mini fellowships.
That implies programs where there's an abundance of volume that would allow that. I've always struggled with that because I I do a lot of elbow, which I don't think is done a lot. And we have a visitor.
We do have a visitor. Did you want to introduce yourself? Okay, go ahead.
My name's Evelina and I'm 6 years old.
Okay.
Evelina, thanks for joining us. We're talking about your future in hand surgery.
She can't hear you because I have the headphones on. Okay. Can Daddy finish the podcast?
Yeah.
Okay. Bye. Thank you.
Yeah, so I do a lot of elbow work, and yet the challenge is having enough to welcome visitors or enough localized. But I think you're right. An upper extremity arthroscopy fellowship makes a lot of sense.
I think you're going to be doing more and more through the scope, and people are going to want to come to learn. And I think I'm going to be doing less and less through the scope, meaning that honestly, and I'm interested just personally. I want to remain broad as a hand surgeon, but I also recognize there's just too many fields to keep up with. Like, to be honest with you, even in our narrow lane of hand surgery, there's various things that I'm just not going to be up on as much. And, I think that I'll probably have to select at some point.
It's so true, and you're wise not to narrow too soon. We've talked about that. I firmly believe stay broad as long as you can. But at our institution, oh, it would be okay if you decided to just do nerve. But you drive 100 miles or even 50 miles or 30 miles outside of the academic institution, and you can't be that narrow. So it does get harder and harder to stay up to date. So yeah, is there going to be increased specialization? And I think that may be the future of hand surgery that you're alluding to. I don't think it's 3A. I think it's 4. I think that we will continue to narrow what hand surgery looks like.
Yeah, but I think it is important to have that broad base, not only for just in access for patients, but my own sanity. I mean, I can't do only nerve because doing only nerve means a lot of pain, and then I need the wins. I need the carpal tunnels, the trigger fingers, the basal joints, the distal fractures. I need balance in that regard to give me the energy to keep going on some of the nerve because the nerve can really drain you.
It's so true. Well, not just nerves. So I've said to my nurse, she doesn't listen to me, but I've said to my nurse, my sweet spot for wrist arthroscopy is 2 in a single day. I'm happy to do 3. When I have 4, it's too much. It's too many scopes.
Total. I've actually I'm now working with a new with an athletic trainer as my primary support person for my team, and she's wonderful. But she booked me I think 4 ulnar nerve transpositions in a day, and I'm like, I love that surgery. I know I do a lot of them, but that's just a lot. And then I told her I have a limit on the number of Volant cases I'll do in a day, and I think because of the way that the scheduling happened, I think I have 6 Wallon cases the day after Christmas, which is just going to be a lot. It's really taxing on my ability to entertain at the same time as doing surgery.
It's a lot. And yeah, 3 or 4 Volants are plenty for me. And I would say the same about ulnar nerves. My goodness, after 3 in one day, it's that's too many.
So one more prediction, maybe. Carpal tunnel releases and trigger finger releases will not be done in the operating room in 2035.
100% agree. 100%. Wait, we got one more after that. 100% agree that we will not be doing the little cases in the OR. And honestly, I don't think it's going to take 10 years to get there.
Okay, well, why don't we, before we jump into the next
Wait, wait,
hot
wait, wait,
take,
wait, wait, wait. I want to do the next hot take. Oh, you're going to thank another
I'm
sponsor?
I'm going to thank our sponsor.
Can't
So
stop that.
we can't stop that. And it's relevant to the next hot take. So the upper hand is sponsored by Checkpoint Surgical, provider of innovative solutions for peripheral nerve surgery. Did you know that Checkpoint offers an accessory to the Guardian Nerve Stimulator, the intraoperative lead accessory, which connects easily to Guardian with a simple push-on motion, enables hands-free stimulation delivery to a consistent assessment site.
This makes it easier to repeatedly assess motor nerve excitability throughout a procedure, such as in a neurolysis or decompression, and also enables repeated confirmation of nerve function in procedures with risk of iatrogenic nerve injury. To learn more, visit www.checkpointsurgical.com. Checkpoint Surgical driving innovation in hand surgery. Can you please translate what I just heard?
You know how so Guardian is the unipolar stimulator. So that's the blue one. That's what I call it, the blue one,
Thank
not the
you.
purple one, which is the bipolar stimulator, which is the Gemini. So the Guardian's the blue one, the monopolar. So you put this little doohickey on it, attaches to it, and then instead of applying the stimulator directly to the nerve, you can then hook a lead on it. It's like a little plastic U shape that can hook around the nerve atraumatically. There are some holes if you want to put a couple of stitches in it to keep it there. But then you can stimulate the nerve consistently without having to take the device on and off, touch it on and off, etc. So um, I think there are other applications that Checkpoint is thinking about down the line for said lead, but I should not say more than that. But yeah, it's a nice way to keep the lead in the same place if that's your goal. To stimulate the nerve in a consistent place if that's your goal.
Gotcha. That's over my head, but sounds interesting. So, what's nerve repair going to look like in 7 years?
I think it's an interesting question because of, for many years, we've been trying to look at nerve conduits, things to get away from sutures, perhaps a sutureless nerve repair. The question is always, does it generate more scar, debris, etc., than it's worth? But sutures also generate scar, and sutures introduce human variability in technique. Um, Newer devices have been introduced, using small hooks that kind of go into the epineurium and can keep a nerve together. I'm not sure that nerve repair is going to go in that direction. I think many will. Many will use said device or a conduit or something to go to a sutureless repair. I still think we need to train our fellows and residents about how to use microsutures to put nerves together. I think there's a training aspect to it. I'd like to see if we can get away from a number of like the vast number of stitches. So maybe go to just a single or two stitches and use something else to keep the coaptation together. Um, my prediction is that these devices will then be used as drug delivery devices. And I think that's probably where things are going to go.
It makes a lot of sense. We've watched our previous chair and senior partner dedicate a career towards the manual suture repair of flexor tendons. And as he sort of finished his 40 years with NIH one funding, he was into the drug delivery game for tendon healing. It just makes sense for tendons, for nerves, or whatever.
I think hopefully that's something that the appropriate cocktail will be figured out, and that's probably not going to be ready for prime time. I think for a solid 1 or 2 decades, but I think this is laying the groundwork for that.
So for doing long-term predictions, are you ready to go off the nerve? Because I know it's tough to stop talking about. Do you have anything else you possibly, there's no more nerve talk this episode.
I
So
want people to email saying how much more nerve they want, or if they want, and honestly, email us and say what you want, right? Like, we have a great grab bag episode that's going to come out in next month at some point. We've had some great emails, so we appreciate all the emails, including some fun facts about the origin of Halloween. So we had a correction. The That'll be a great episode. But if you want more nerve, please email us handpodcast@gmail.com. And more of anything. I'm sure you want more sports. Whenever I see people in person, they always talk about how they want more sports and arthroscopy stuff. So I admit I do enjoy learning during those episodes. So thank you for that.
absolutely. So I'll talk a little bit what I think the future of congenital hand surgery is.
Oh man,
Um,
you didn't tell me we were going congenital on this episode.
there's been a clamoring. The listeners
So
want
for the
more. It's
three of
been
you that like congenital, please keep listening. If you're not into congenital, just you can keep listening to it. It's fine.
this is going to be short and obtuse. Gene therapy will be there one day. Right now, gene therapy is super expensive. We're using it for, obviously for cancer. There's been some work done with sickle cell, and it's going to be arthritis, et cetera, et cetera. So maybe CMC arthritis doesn't exist anymore with gene therapy, but I think gene therapy will change the way we think about congenital conditions. I'm not smart enough to know exactly what that means, but I don't think we'll be treating the same volume in 15 years that we are today.
That's exciting. the problem is that we're producing so many congenital hand surgeons. Everybody wants to do congenital. I just read every fellowship application that we received. I mean, the number of people that want to do peds and congenital, I'm like, good God, do we need another congenital hand surgery
We
surgeon?
newsflash, we probably don't. But maybe I need to retire. So there's space, there's room.
So quick question. Do you think gene therapy for arthritis will be ready before an accepted thumb CMC implant in the United States?
I think it might be. I think it might be. And the work that our colleague and our partner Farsh Gilak is doing in regards to osteoarthritis and treatment, it's unbelievable. For those of you who, and I can't speak eloquently about it, but the work being done in the lab for osteoarthritis and treatment for it is unbelievable. We're not that far away to Chris's point. Yes, I'm voting for gene therapy
I think
before.
gene therapy will get there before a thumb CMC implant is widely adopted in the United States. Patients, I have to answer that question a lot. I mean, like my whole spiel about arthritis is that we have no cure for it, but they're working on it at WashU. I mean, Farsha received the largest grant in WashU history. It's an incredible amount of money. So yes, see, they're working very hard on fixing that. One other question before we close. Do you ever think that there will be in utero surgery for congenital hand issues?
So there currently is theoretically, the problem today is the risk of like if you have a constriction band around the forearm or upper arm that's severe, I think our general surgery colleagues would potentially treat that in utero. But most of the other stuff is the risk benefit ratio is off. I don't know how that changes. I'm just not that knowledgeable, but yeah, I think that'll increase as well. I do.
Okay.
I
Any
have one.
other? Go
Yes,
ahead.
one important one. How many hand surgery podcasts will there be in 2030?
So interestingly enough, I did look a lot last week. I can't remember what prompted me to do it. There are a couple other hand surgery podcasts that have a limited run of episodes. I can't say that anybody has, 5 years in a game like others, but it's crazy. We're going up on our 5 year anniversary next month.
Who would
I
have
feel
thunk
like
it?
I feel like you owe me a gift. Like
This is your gift.
that's right. But yeah, no, I don't know. Maybe. I don't know if there'll be one hand surgery podcast in 5 years. We'll see.
I wouldn't bet on it.
You're awful busy. So
Too
um
funny.
I don't know. And I think that yeah, who knows what the next educational kind of venue is going to be. I mean, I think that fortunately we were, I wouldn't say ahead of the curve, but we were timed appropriately, I think, with the upper hand. But who knows where it's going to go.
Yeah, and for those of you, listen, we're grateful for our listeners. This is a labor of love. We do enjoy it for sure. What's been fascinating for me, and that goes to the listeners who are still tuned in and haven't dropped off yet. Most of you listen in the audio only format, but our YouTube viewership, why people want to see Chris and me sit here and talk, I do not know, but our YouTube viewership is going through the roof. I mean, I think we had 600 or 700 recently. It's really remarkable.
I think it's just easier to pull stuff up on your computer or your phone on YouTube
Maybe
and
that's
just
it.
like let it roll. That might be it, or I mean, they love seeing your dome. It's great.
I got a shortcut. This is what happens.
Looking good. Well, I wish you the best holiday season and a great end to your 2024, Chuck. It is always fun to do this together, and I look forward to another year of it, hopefully. Let's see if we get
Absolutely.
renewed.
All right. Happy holidays.
Happy holidays. Take care.